Tension-type headache, often abbreviated as TTH, is the most common primary headache disorder worldwide. Affecting over a quarter of the global population, TTH can range from infrequent mild episodes to chronic disabling pain that significantly impacts daily life. Unlike migraines, TTH is typically described as a bilateral, pressing or tightening pain of mild to moderate intensity, and usually lacks symptoms like nausea or sensitivity to light and sound. While episodic TTH is more prevalent, chronic forms can lead to increased healthcare use and disability. Understanding TTH's hallmarks is crucial for effective diagnosis and management, as it often overlaps with other headache types and can be influenced by a variety of biological, psychological, and lifestyle factors. Tension-type headache is highly prevalent across all age groups and regions, with a global prevalence of about 26%. It affects both men and women, though there is a slight female predominance. The condition is particularly common in adults but can also be seen in children and adolescents. Prevalence estimates vary due to differences in diagnostic criteria and research methods, but TTH remains a leading cause of disability and reduced quality of life. Chronic TTH, though less common than episodic forms, has a more profound impact on daily functioning and healthcare utilization. Recognizing the widespread nature of TTH helps highlight the importance of accurate diagnosis and tailored treatment strategies. Tension-type headache is classified based on frequency in episodic, ETTH, and chronic CTTH forms. Episodic TTH is further divided into infrequent and frequent subtypes. The International Classification of Headache Disorders, ICHD-3, provides criteria for diagnosis, focusing on headache frequency, duration, and associated symptoms. However, distinguishing TTH from mild migraine can be challenging, especially when symptoms overlap. Strict diagnostic criteria improve specificity but may miss some cases, while broader criteria risk misclassifying patients. Ongoing research aims to refine these definitions, ensuring more accurate diagnosis and better patient outcomes. Diagnosing tension-type headache can be complex due to overlapping symptoms with migraine and other headache disorders. TTH is characterized by bilateral non-pulsating pain without significant nausea or sensitivity to light and sound. However, mild forms of migraine can mimic TTH, leading to potential misdiagnosis. Strict diagnostic criteria help differentiate TTH from migraine but may exclude patients with mixed features. Ambiguous patient descriptions and evolving symptoms further complicate diagnosis. As artificial intelligence models become more integrated into clinical practice, the need for clear, standardized diagnostic input is increasingly important to avoid misclassification and ensure appropriate treatment. Longitudinal studies reveal that headache diagnoses can change over time, especially in children and adolescents. Up to 71% of individuals may experience a shift in headache classification over several years, with some initially diagnosed with TTH later developing migraine, and vice versa. Remission rates also vary, with some studies showing that a significant proportion of individuals become headache-free over time. These findings highlight the fluidity of headache disorders and the importance of ongoing monitoring and flexible treatment approaches. Understanding these transitions helps clinicians anticipate changes and adapt management plans as needed. Underlying mechanisms of tension-type headache involve both peripheral and central factors. Early theories emphasized muscle tension as the primary cause, but recent research points to central sensitization and altered pain processing, especially in chronic TTH. Neuroimaging studies show changes in brain regions responsible for pain modulation, such as the anterior cingulate cortex (ACC) and insula. Genetic predisposition, vascular factors, and psychological stress also play roles. This complex interplay underscores the need for a multidisciplinary approach to both research and clinical management, targeting multiple pathways to achieve optimal outcomes. Structural and functional neuroimaging studies have provided valuable insights into the brain changes associated with tension-type headache. Chronic TTH patients often show decreased gray matter volume in regions like the ACC, insula, and cerebellum, with these changes correlating with disease duration and frequency. Episodic TTH may present with increased gray matter in certain areas, suggesting different mechanisms at play depending on headache frequency. Functional imaging also reveals altered activity in pain modulation networks. These findings highlight the importance of the brain's role in TTH and may guide future diagnostic and therapeutic strategies. Electrophysiological studies in TTH reveal distinct patterns between episodic and chronic forms. While episodic TTH often shows normal responses, chronic TTH is associated with increased peripheral muscle activity, heightened brainstem excitability, and lower pain thresholds. These changes suggest that chronic TTH involves sensitization at the brainstem level, rather than the cortex. Reflex testing and pain sensitivity assessments further support the role of central mechanisms in chronic cases. Understanding these neurophysiological differences is key to developing targeted treatments and improving patient outcomes. Genetic studies indicate that TTH has a heritable component, especially in cases without comorbid migraine and in chronic or frequent episodic forms. Polymorphisms in genes related to neurotransmitter function, such as 5-HTTLPR and COMT, have been linked to increased risk. Molecular mechanisms involve the release of nociceptive mediators from muscle trigger points, leading to local inflammation and sensitization. Central sensitization is further driven by changes in neurotransmitter levels, including serotonin and norepinephrine. These findings suggest that both genetic and molecular pathways contribute to TTH, offering potential targets for future therapies. Enteral mechanisms, including central sensitization and impaired descending pain modulation, are central to the chronification of TTH. Persistent nociceptive input from peripheral structures leads to heightened responsiveness in central pain pathways, involving the dorsal horn, trigeminal nucleus, and thalamus. Neuroimaging shows structural and functional changes in regions like the ACC and insula, especially in chronic cases. Nitric oxide pathways and neurotransmitter dysregulation further contribute to central sensitization. Addressing these central processes is essential for preventing the transition from episodic to chronic TTH and improving long-term outcomes. Peripheral factors, such as pericranial muscle tenderness and myofascial trigger points, play a significant role in TTH pathophysiology. Muscle tenderness is more common in chronic TTH and is associated with increased headache frequency and severity. However, the relationship is not straightforward, as some patients with significant tenderness have mild headaches and vice versa. Myofascial pain can be induced experimentally, supporting the role of peripheral sensitization. Treatments targeting peripheral mechanisms like manual therapy and acupuncture have shown benefits, though the exact causal pathways remain under investigation. Like migraine, vascular mechanisms and the neuropeptide CGRP play a less prominent role in TTH. Studies on blood flow and cranial hemodynamics in TTH have yielded inconsistent results, and CGRP levels are generally not elevated except in patients with migrainous features. It suggests that TTH is less driven by vascular or CGRP-mediated pathways, distinguishing it from other primary headache disorders. Understanding these differences is important for guiding treatment choices and avoiding unnecessary therapies targeting vascular or CGRP pathways in typical TTH cases. Tension-type headache often co-occurs with other conditions, including musculoskeletal pain like back and neck pain, temporomandibular disorders, fibromyalgia, and psychiatric disorders such as anxiety and depression. Sleep disturbances, gastrointestinal issues, and even systemic diseases like hypertension and hypothyroidism are also more common in TTH patients. These comorbidities can exacerbate headache burden, complicate treatment, and impact quality of life. Recognizing and addressing comorbid conditions is a key component of comprehensive TTH management. Non-pharmacological interventions are increasingly recognized as valuable components of TTH management, especially for chronic or refractory cases. Neuromodulation techniques such as transcranial magnetic stimulation (TMS) and peripheral nerve stimulation (PNS) show promise in reducing headache frequency and intensity. Cognitive behavioral therapy (CBT), mindfulness, and lifestyle modifications like regular exercise, sleep hygiene, and stress management are also effective. These approaches can be tailored to individual patient needs and often complement pharmacological treatments, providing a holistic strategy for managing TTH. Lifestyle management is a cornerstone of TTH prevention and treatment. Keeping headache diaries, managing alcohol and smoking, and maintaining regular sleep patterns are key strategies. Dietary factors such as avoiding certain triggers like processed foods, alcohol, and skipping meals can help reduce headache frequency. Nutraceuticals like magnesium, vitamin B12, and niacin have shown potential benefits, though more research is needed. Encouraging healthy habits, stress reduction, and social support can significantly improve outcomes and reduce reliance on medication. Physical therapy, exercise, and patient education are effective non-drug interventions for TTH. Strengthening and stretching exercises targeting the neck and shoulder muscles can reduce headache frequency and intensity. Manual therapy, massage, and soft tissue techniques help alleviate muscle tension and improve function. Patient education about posture, trigger point management, and self-care strategies enhances adherence and long-term outcomes. Combining different physiotherapy approaches often yields the best results, especially for chronic cases. For acute episodes of TTH, over-the-counter analgesics like NSAIDs and paracetamol are first-line treatments. NSAIDs are generally more effective, but paracetamol is preferred for patients at risk of gastrointestinal or renal side effects. Caffeine can enhance the efficacy of analgesics but should be used cautiously to avoid medication overuse. Preventive medications such as amitriptyline and mirtazapine are recommended for frequent or chronic TTH. Treatment plans should be individualized, considering patient preferences, comorbidities, and potential side effects. Prognosis for tension-type headache is generally favorable, with many individuals experiencing remission or reduced frequency over time. However, chronic TTH can persist and significantly impact quality of life. Factors associated with poor outcomes include coexisting migraine, psychiatric comorbidities, and medication overuse. Long-term studies show that headache types can evolve, and ongoing monitoring is important. Early intervention, comprehensive management, and addressing comorbidities can improve long-term outcomes and reduce the risk of chronification. Tension-type headache affects not only physical health but also psychological well-being, social relationships, and work productivity. Chronic TTH is associated with increased rates of anxiety, depression, and sleep disturbances. It can lead to absenteeism, presenteeism, and reduced quality of life. Family and social interactions may be strained, and patients often feel misunderstood or unsupported. Addressing the psychosocial aspects of TTH through counseling, support groups, and integrated care is essential for holistic management. Despite being less severe than migraine on a per-person basis, the high prevalence of TTH results in a substantial economic burden. Direct costs include healthcare visits, medications, and diagnostic tests, while indirect costs stem from lost productivity due to absenteeism and presenteeism. In some regions, indirect costs account for over 90% of the total economic impact. Underdiagnosis and undertreatment further exacerbate the societal burden. Public health initiatives focused on early diagnosis, education, and equitable access to care are needed to reduce the overall impact of TTH. Tension-type headache affects individuals at all stages of life, from children to older adults. In children and adolescents, TTH can impact academic performance and social development, with lifestyle factors like screen time, diet, and sleep playing significant roles. In adults, occupational stress and lifestyle habits are key contributors. Older adults may experience changes in headache patterns due to comorbidities, polypharmacy, and social isolation. Management strategies should be tailored to each age group, emphasizing prevention, education, and multidisciplinary care to address the unique challenges faced at different life stages.